Good afternoon, everybody, and welcome to the 2021-22 Annual General Meeting of the Black Country and West Birmingham Clinical Commissioning Group. Unfortunately, the chair of the CCG, Salma, is not able to be with us today, so I will be taking the role of hosting this meeting, and thank you all for joining us. Hopefully, you'll have just seen on the screen how to set up the captions for those that require them. And of course, this event, even though we're doing it virtually, is an opportunity for you to ask us any questions that you want to. As always with AGMs, we can't discuss issues that are sensitive or personal cases, and later on in the presentation we'll give you the contact details where that is the case. But it is an opportunity for you to ask colleagues that we've got on the session today, who you'll meet in due course, to ask any questions about the achievements of the CCG over the past 12 months and also our plans for the future. With Salma not being with us, I thought I'd share from the annual report, which we are about to publish, some of the thoughts that Salma shared in her forward to the annual report. And actually there are sentiments that I think are shared by very many of us. So the previous year, 2020-21, was a year of great challenge for health services, as you all know. It was the year that COVID came and became part of the way we work. And probably this time last year, as we ended 2020-21 and headed into the new year, 2021-22, at that point in the year, COVID cases had subsided a little. We'd started the vaccine programme. And I think there was a sense that, what would the future bring for how we deliver health services? What have we learned from the previous 12 months? But certainly the year 2021-22 has brought dual challenges and pressures, I would suggest. We saw the significant impact and the challenges that the wave of Omicron gave to our population, to our services, to our staff, whilst at the same time making sure that we do all that we can to continue to restore and recover the delivery of elective care services, cancer, meet the challenges of urgent care demands. And you'll hear more about the huge efforts that have gone into those during this presentation. And of course, we should also not forget the additional ask, which was the immense ask and response from partners right across the system to continue the vaccine rollout right across the Black Country and West Birmingham. 2.6 million vaccines delivered. So a huge amount of pressure, a huge amount of change to deliver on, and also the opportunity to learn and listen to our communities in the way we shape services. And certainly my thoughts go to the challenge of delivering the vaccine programme during the year, where we've learned so much about communities. Vaccine hesitancy was certainly a challenge that we faced into and worked very closely with communities to address, and something that we need to continue to build on. So COVID has continued to be right at the forefront of our work, and our staff as a CCG and those working right across primary care have been absolutely outstanding in extraordinary circumstances. And I think that continues and builds from 2021 and continues right through until 21-22. So I would like to put on record my thanks for everybody's work, their commitment, their extraordinary effort. And it was great last week to be able to recognise some of that as part of an event we held as CCGs come to an end, to say thank you to staff. And again, we're in a position at the moment where we start a new year wondering what next. COVID levels are lower, although we need to continue to be vigilant, and we are seeing indications that the levels of COVID are increasing in the community. So again, we start the year with an absolute focus on recovery and restoration, but also being vigilant around what the future for COVID means and what future challenges mean for our population. And I think in the annual report that's now available, Salma has probably written the best possible message, and as she can't be with us, I'd like to read it out to you. And it goes as follows. On behalf of our governing body, I particularly want to record our thanks to our dedicated staff in the CCG and our member practices for their incredible efforts and dedication. They've shown commitment to the people of the Black Country and West Birmingham, and I want to publicly acknowledge all the hard work and thank each and every one of them for the positive impact that has been made and how they've supported each other over the past year. I think that message is perfect and entirely sums up the views of the CCG governing body, who met in public last week and put on record their thanks to everybody, and certainly echoes what I would say and my thanks to everybody and the efforts I've seen, having been with the CCG just a short time myself, and that dedication and commitment shines through. Having been with the CCG for a short time, I'd also like to say thank you to my predecessor, Paul Moback. Most of the work you'll see in the annual report, most of the work that you'll hear described today is down to his leadership and the team that works alongside him. And I'd also like to express my thanks to CCG governing body members. It's now some circa 900 days since COVID became part of our lives, and there is no doubt that we face a long and difficult recovery time ahead. But hopefully you'll hear through the presentation today the immense efforts that are going on across the Black Country and West Birmingham to keep on developing services and keep on delivering services in these unprecedented times. Next slide, please. A bit about us, for those of you that are new to this AGM or new to the CCG. So collectively, we serve 1.5 million local people, and there are 208 GP member practices across 31 primary care networks. And our main role is to plan and buy healthcare for patients who are registered with a GP in the area that we cover, that being Dudley, Sandwell, Walsall, West Birmingham and Wolverhampton. And our collective vision, the collective vision of the member practices, the PCNs I've described there, but actually our wider partners across the Black Country and West Birmingham, is to kind of strive for a healthier place with healthier people and healthier futures. And certainly you'll hear later on in the presentation, as we start to talk about our future, that becomes even more relevant as we start to think about health inequalities, access to services, and how we develop services in the future to meet the demands that are ahead. We absolutely work strongly with partners and communities in making those decisions, and we should say thank you to our partners, our communities, for all the work and engagement they've shown through us during the past year, to our 4 local authorities, our trusts, our voluntary sector across the Black Country, Health Watch and other engagement partners that we've worked with to really start to shape how we deliver services. So a huge thank you to colleagues that continue to work with us on shaping what we do. And as a CCG, we have a number of key duties. One is to continue to improve quality of services commissioned, to promote the NHS Constitution, to commission a comprehensive set of health services for our population, and to continue to do all we can to reduce inequalities. Next slide, please. Our priorities were set for the year, and we've worked in partnership with key stakeholders across the system to help support restoration and recovery, manage COVID-19 and prepare for that moment around system reset that you'll hear more about soon. Right at the top of the agenda has to be the support in terms of the health and well-being of our staff. We cannot deliver and would not have got through the last 2 years without the amazing commitment of our staff, the 500 staff in the CCG, some of whom were deployed really short notice into different roles to meet the challenges people face, but actually the health and well-being of staff right across the system, both in terms of the pressures and challenges that they face through COVID, but also making sure they feel supported at any time and that the organisation is there to support them. I've talked a little already about delivering the NHS COVID vaccine programme and continuing to meet the needs of patients with COVID-19. Matt will take you through some of the headlines in terms of restoring elective and cancer care and meeting some of the increased demand around mental health, primary care and urgent care services. And of course, we know COVID has shone a light on, and some of the vaccine programme has really highlighted the importance of health inequalities. The Black Country has a population of 1.5 million, geographically a very small area, but we know the demands of our population are very different depending on different parts of the Black Country that you live in, and when you compare it to some of the national indicators, for example, deprivation, some of our population live in some of the most deprived areas of the country. It's a huge amount of work to be done and continue to be done, and will be a priority for the Integrated Care Board. Next slide, please. So I'm going to hand over at this point to the Chair of Audit and Governance Committee, Mr. Jim Outridge, who will take you through the audit opinions for the accounts and the reports that we are presenting for 21-22. Jim, over to you.
Thank you, Mark, and thank you for those introductions. Good afternoon, everybody. As Mark has indicated, the slide says, I have had the pleasure of chairing the CCG's Audit and Governance Committee over the last 12 months. And during that time, we have, and certainly in the last 2 months, we have had external auditors in. They are Grant Thornton, one of the big audit companies in the UK, and they've reviewed our accounts, our governance arrangements, and looked at our overall financial position. And as you can see from the slide, the audit began back end of April and was concluded only last week when the governing body and the audit committee signed off the accounts as being satisfactory. Throughout the external audit, there's been a significant amount of testing takes place to ensure that all our transactions are correct and contained within the accounts. And the external auditors also ensure that the words that we use and the descriptions that are reported in the report and accounts reflects the performance of the financial statements, so that the financial statements and the reports that go alongside it do actually gel with each other. At the conclusion of their audit, Grant Thornton has issued an unqualified opinion following the audit of the 21-22 accounts. And in effect, let me just explain what unqualified opinion means. It means 3 things. Firstly, that the report and accounts have been, do give a true and fair view of the activities within the CCG for the last 12 months. Secondly, it means that the accounts have been prepared in accordance with national and international accounting standards that operate throughout the world. And thirdly, it also means that we have prepared our accounts and presented our accounts in accordance with the requirements of the NHS in terms of the way in which NHS accounts are prepared. As well as external audit, each year we have a rolling programme of internal audits where those audits are pre-planned before the year starts and delivered throughout the year. In the last 12 months, that delivery has been undertaken by Coventry and Warwickshire Internal Audit Services, commonly referred to as CW Audit. And they've systematically reviewed our controls, our processes throughout the year. So in effect, it's almost as though there has been a continuous internal audit activity throughout the last 12 months. We've listened to the views and experiences that they have produced for us and taken on board recommendations and implemented those recommendations. Just to give a flavour of the extent of internal audit, throughout the last 12 months, 13 audits have been undertaken and reports prepared on each of those audits. And of the 13, 10 received a very high opinion in terms of the level of assurance. That's 3/4 of our internal audits actually had a significant or full assurance rating by CWA. And as a result of that, the head of internal audit opinion, this is a specific named individual who produces an opinion on the overall internal audit activity during the last 12 months, the head of internal audit overall opinion was rated as significant assurance, which means that the CCG is deemed to have a sound system of internal control. So if I can just go to the next slide, please. We'll see from that last week at the final audit meeting, which I chaired, the overall conclusion from the audits were that the committee concluded that the financial accounts for the period 21-22, as signed off by Grant Thornton, our external auditors, with an unqualified opinion, these are recommended to this AGM for adoption. And we would like to think that you'd be pleased to adopt a really splendid outcome for the year. So thank you very much for that. I would now like to pass on to Matthew Hartland.
Thank you, Jim. Welcome everyone. My name is Matthew Hartland. I'm the Deputy Chief Exec of the CCG, and part of my portfolio is to give the board assurance as to where we are with our performance and our planning for the year that we're discussing through the annual report. So Mark's described earlier the context in which we've operated during 21-22 from a system perspective in terms of managing our performance. What that means with both the resurgence that we had of Omicron is it was a bit of a hybrid year in terms of expectation from us from a system, both in terms of managing the demand that COVID brings us and making sure that that's done in a safe and transparent way to our public, but also alongside the need for us to start recovering our services and ensuring that all of the services that we deliver are back online and start supporting our population on those services that we stood down. One of the areas that, or one of the issues that faces, is that COVID actually gives us less capacity to operate in as a system. We continue to have to maintain our COVID and non-COVID segregation within our facilities, and also the impact it had on our staff sickness, and ensuring that we had the ability to be able to manage and maintain within our whole system the services that we were there to deliver. So ultimately, what happened last year is that we had less ability to do what we might classify as routine work that would be governed in a normal year for us as the NHS, and for us to concentrate on some of the more time critical care that we know that we needed to deliver. And ultimately, as a system, there are areas where we continue to perform really well. We prioritised what we believe to be the most safe and effective work that we did, but also it means that in certain areas we've not been able to achieve the levels of performance that historically we've done well on due to the pressures that we faced last year. So next slide, please. So the annual report describes in quite some detail where we are in terms of our performance, but I'm going to draw out 2 or 3 of the issues that we faced last year and we continue to face now. I think one of the biggest issues that's a consequence of COVID, not driven by COVID, is the impact that we're now facing on ambulance handovers. So we do recognise that this is our biggest system-wide operational challenge at the moment, because we've got too many individuals and ambulances waiting outside hospital. This is a significant priority that we have with our system partners and working with the ambulance service to make sure that that's reduced, but it'll be done in a safe way. And that's a really important part to recognise, and also recognising that it's a system-wide initiative for us to be able to do so. And that is continuing through to where we are now. It is improving, but unfortunately that's the position that we were at the end of March. But some good news is that even though our total waiting list has risen, as would be expected because of what we've been through for the last 2 years, our ambition to ensure that we have no 2-year individuals on the waiting list, i.e. 104-week waits, we're confident that by the end of June, which is in 4 days' time, that target will be met. and at the end of March, which is the year in which the annual report is, we were on trajectory, and it's really comforting to be able to tell you that as it stands at the moment, we will be having no one waiting longer than 2 years at the end of June. So that's really good news. Next slide, please. And what we've got on this slide are those areas where the constitution targets by which we're established as a clinical commissioning group are still valid. But as you would expect to see, based on what we've said, some of our performance was less than we've seen historically. Obvious ones in there are things such as the 408 with an A&E, but also we have done well, and we've deliberately targeted some of the areas where we know there are issues and concerns that our patients have told us. So we've done well in some of our mental health recovery standards and also our cancer drug treatments. Where we've shown on this slide where we've not been able to achieve the targets, predominantly in cancer, as shown on here, we are doing well in the 22-23 financial year we're in at the moment to recover those to the point where we do believe that we'll be achieving our expectation of a set by NHSI at the end of the year. So that is an improving position. Next slide, please. So it's important to recognise that alongside achieving what are the expectations of us as a system, we've also done really well in a number of other areas where we as a system have chosen to direct our resource, our efforts to do not only what's required of us through the NHS long-term plan, but also what our public have told us is important to them. And so what this slide describes is a number of achievements that we believe we've done really well and are really proud of what we've achieved in the last year, and taking into account what we and our providers and our population have all faced. So Mark's mentioned the 2.6 million vaccinations that we've done this year. We've also done really well in our eyes on developing our place-based partnerships. And that's really important for us because we recognise that in the future, that's where the majority of the decisions on the health and care needs of our population will be based, by talking to the public at place and establishing the governance and the partnerships to be able to deliver care in a way that we haven't been able to do differently with our wider partnership is what we're looking to achieve. We've made really good progress on that. And then also on there as well, you'll see that we've established within the Black Country this year the first paediatric virtual ward in the country, and that was established at the Dudley Group of Hospitals. And that's a brilliant way that we've been able to utilise the technology to be able to make sure that those children haven't had to visit hospital. So fantastic effort that we've got there, which is going to be replicated both within the Black Country but also nationally, with some great work that we've undertaken this year. Next slide, please. The other thing as well that we made a conscious decision on is to continue our investment and our work on reducing inequalities. Mark said earlier that's one of our key priorities, but that's not the only reason that we do it. It's because we believe that that's the reason that we're here, to have a longer term investment into making sure we've got that larger impact on our inequalities and our associated life expectancy that goes with those. There are a number of schemes that we've undertaken this year that contributes to that. What we've got on the slide at the moment are two that we just wanted to draw out, where what we did is in our partners with the voluntary sector and local authorities, we asked for expressions of interest this year as to some initiatives that would benefit from investment from ourselves to reduce inequalities, and two great schemes that we've done with Walsall Housing and also the Your Health Partnership for Mental Health. That's worked really well for us, and there are a number of these that we'll continue to do this year, and we really are seeing the benefit of those as we move from what we faced into the new way of working, and that's entirely and exactly what it is that we'll be doing as we progress. And also finally, the Black Country Anchor Network. That's not something that's an investment, but it's a different way of working that we're looking to embed with partners that ensures that everyone recognises the role that the NHS with our other agencies plays within the Black Country and within West Birmingham. So there are some key priorities that we've got here about making sure that we award contracts to suppliers within the Black Country we contribute to net zero, but also make sure that our employment is targeted on those individuals that not only want to work in the Black Country but also live here. So again, that's a really important initiative as well that we're taking forward. And then finally, the final slide just builds on what I've just said as the work that we've done. We can't achieve what we want to do in health without working with our partners, and that includes the local authorities. We've had health and wellbeing boards within our infrastructure since CCGs were formed in 2012. And what this slide does, it just shows some of the great comments that we've had from the chairs of our health and wellbeing boards. It shows the value and the benefit that we've got as we've been working closer together over the last, certainly 2 or 3 years, but certainly within the last 12 months. This is what we need to build upon. This is what we will build upon. But this is just some of the great comments that we've had from them that basically builds that framework for this to continue. So happy to take any questions afterwards. There's more detail in the annual report, but I'll hand back over to Mark, please, if I can do on quality.
Thank you, Matt, and thank you, Jim, as well. The next section is on quality. Unfortunately, our chief nurse, Sally Roberts, is not able to be with us today. So in presenting this to you, I'd just like to say thank you to Sally and her team for the immense work that they've done. Next slide, please. So from a quality and safety perspective, there's been a number of priorities. Obviously, you'd expect quality and safety to be right at the top of the agenda in terms of how we do things as a CCG. And absolutely, as we've merged the 4 CCGs, making sure we do all we can to build capacity and resilience to support the CCG in acting on some of those statutory duties we described earlier on in the presentation. And part of that, I guess, because of the level of challenge that we've got in the system, is about building resilience, and particularly building resilience in our place-based safeguarding teams through their designated functions, developing individual placement reviewing officers, but also making sure we've got resilience and capacity through continuing healthcare, and preparing the team and the way we learn around quality and safety. We hold ourselves to account in a way that's kind of ready for the way we want to work as we become an integrated care board. As the team have had kind of portfolios that they've developed over the last 12 months, with key work streams being around primary care, care homes, urgent care, patient safety and health protection and infection prevention. Some of those are themes that build on kind of the quality and oversight as some of the challenges Matt has already described to you, or certainly with infection prevention, very much linked to the challenges we've seen and have seen through COVID, and making sure that as a system we make the right moves, take the right steps to keep people safe, but also make sure we learn and shape that with other partners. And it's been great to see the team work collaboratively with partners across all of the health and care, including third sector organisations. And that's really driven a kind of culture of quality improvement, sharing of good practice, identifying of where multi-agency working can improve, particularly to avoid duplication, and in addition revise the strength and the quality of our quality strategy to support all that we are doing. Some particular areas of focus: ageing well, so particularly we want to support older people in out of hospital care. So the key work streams have been looking at the quality and safety of care homes, extending the provision of virtual wards. Matt mentioned virtual wards in his presentation, but we were already leading the way in terms of virtual wards, particularly around older people, and making sure that that learning is rolled out across the system, and particularly making sure that where we do implement virtual wards or remote monitoring at home, that people feel supported by both acute and community teams to keep well at home. And in particular, we've developed the urgent 2-hour community response teams to help where needed and to prevent hospital admissions. Living well, which focuses on the quality of primary care services, including the ongoing development of the general practice nurse workforce, supported by a GP practice lead nurse and a GPN practice facilitator. Staying safe. So as we've gone through the change from 4 CCGs to 1, We go from one CCG to an integrated care board, making sure that we're merging the legacy systems into one and we don't lose anything as we merge those. But also taking the opportunity to improve, to ensure we've got greater oversight of serious incidents and never events, that we are scrutinising themes and trends, and kind of having a schedule planned out for the 12 months that gives us the opportunity to do shared learning across our various providers, in a culture of kind of openness and transparency and positive reporting. Access and response kind of links into the recovery and restoration work you've just heard about, making sure that we've got improvements in access for residents across the Black Country and West Birmingham, as well as where needed, the quality team taking the lead on hosting system summits where there's a particular learning aspect. So there's been a system-wide summit on ambulance handovers. I think there's probably been 2 in the year around CAM services. And of course, we've talked a little bit about the prevention already, the successful delivery of the seasonal flu campaign, the continuation of the COVID-19 vaccination programme. And of course, the team have developed the joint vaccination board, which has brought all system partners together to deliver that vaccination programme at pace. And I think it has to be recognised, the immense efforts and the speed of rollout of the vaccination programme. And that's testimony to the collaboration between local authority health protection teams, directors of public health, CCG teams, and all our partners, that we were able to do that so quickly. Next slide, please. And of course, with learning being at the heart of it, one of the keynote reports that came out during the year was the Ocondom Report, led by Donna Ocondom. This looked into the failings in terms of care for families at Shrewsbury and Telford Hospital in terms of maternity. And all 4 of our maternity units in the Black Country and West Birmingham CCG have submitted fully compliant action plans against part 1 of the actions that came out of the Ocondom Report. They've been shared through the CCG governing body. They've also been shared with our NHS England colleagues. As part of that learning, we put in revised governance and strengthened leadership in place across the maternity network, making sure with a particular focus on workforce, a particular challenge for maternity services. And where needed, we've done deep dive analysis into maternity incidents to ensure that we are identifying any trends and learning. And the work and the learning and the response to the Ocondom Report will continue into 22-23. And I'm sure you'll hear us talking again about this at our AGM next year. In addition, to prepare ourselves to be an integrated care board from the 1st of July, we've implemented a system quality oversight committee. That is absolutely about bringing partners together to look at patient pathways across organisations, to look at the quality of services across a particular condition, to look at how we develop new pathways and learn from each other, and to make sure that where there's any variation in quality, that we're looking at it, addressing it, or have a plan to address it. And this meeting is particular meetings that attended some all acute mental health and ambulance providers, as well as primary care, Care Quality Commission and NHS England as our regulators. And it's been great to have Health Watch around the table, as I described earlier, who, along with other mechanisms, bring that public voice to the table in what we do. Next slide. At the heart of this, and if any of you've heard me talk publicly before, so clearly we're all very excited about the change to integrated care board and the opportunities that that brings for the population that we serve. But it's really important that we don't lose sight of the people that do the day job, that make that difference, and that's our 500 staff across the CCG. They will clearly be going through a second change in a small amount of time. They merged from 4 CCGs into 1. They will now transfer over to be part of the integrated care board, and employee wellbeing has to be at the heart of what we do. Our staff are our most valuable and valued assets, and it's really important that we look after them. So some of the highlights of what we've done during the year: we've continued to support safe working from home for staff. Develop and support of staff representative forums, and there are many actually in the CCG. We've obviously got our trade unions, but also forums that focus on particular areas where we want to improve, and we want to make sure that we are taking action that is meaningful and relevant to the challenges that we have. And a great example is our inclusion forum for race, equality and equity. I've had the great privilege of attending some of those meetings, and we know that we can do more around that particular agenda to make sure that staff from different backgrounds have a kind of equal experience in being an employee of the organisation. And those will continue as we move forward into the ICB, and it's really important that they continue to have a voice in the organisation, but also have the ability to take action and address where things need to be improved, either as a group, and we empower them to do that, or actually as part of some of the bigger developments that we will take forward. Our staff surveys has indicated improved perceptions of staff in terms of the support they are getting, and that's really good that the staff are giving us that feedback. We've seen a gradual implementation of the agile working policy, and we're now starting to see very gradually and in a very planned way, people start now to come back into the offices and start to see the benefits of face-to-face working in terms of bringing teams together. Some of our teams have never met some of their colleagues because they started through COVID. Some of them have never met their executive directors, and it's really important that we continue to develop the benefits of face-to-face working as we develop as a team. And of course, we've had to go through management of change in terms of the process of merging the 5 CCGs. With no involuntary job losses, we've managed to fill vacancies, and as part of our plans as an organisation, improve BME representation across the organisation. And then just finally, as I've mentioned, we had a staff celebration event last week to say thank you to colleagues, and particularly to recognise long service, 20, 30 and 40 years in some cases. And it was great to be able to say thank you to those staff. And you will have seen in some of our publications and press releases some great case studies of people that have shown immense commitment to the health service, not only during the last 2 years of COVID, but over 20, 30 and 40 years. And it was great to say thank you to them. Next slide, please. Over to James now, who's our Chief Finance Officer, who will talk about our accounts and financial performance. James, over to you.
Thanks, Mark, and good afternoon, everybody. My name is James Green. I'm the Chief Finance Officer for the CCG. And this afternoon, I'll be formally presenting the accounts for the 2021-22 financial year to the AGM. The full annual report and accounts can be seen on the CCG website, and if you wish to download a copy, you can see it there. The slides today do extract some of the information presented in the accounts, hopefully in a more user-friendly format. And if we could move on, please, to the first slide. Okay, I thought I'd start by just explaining how resources flow through to the CCG. Now, Parliament will vote on the amount of money that the public sector is allowed to spend, and then each year the Treasury will divide that resource across all of the government departments. And for 21-22, the Department of Health and Social Care received around £190 billion for health and social care. NHS England received 136 billion of that, and NHS England then divide that subsequently down to all of the clinical commissioning groups, and our CCG received just under £3 billion for the full year. Next slide, please. Some of the key headline points from our financial performance during the last year is that, as you've seen from the previous slide, our resource limits of just under £2.9 billion, and on that we delivered a £6,000 surplus for the year. We also are required to operate within what's called a running cost allowance, and that basically is the amount of money that we're allowed to spend on the administrative operations of the CCG. And the target for the year was £27.4 million, and we're not allowed to spend more than that value. We actually spent £24.1 million, which is we were under that target by £3.3 million, and what we're able to do is to reinvest that into patient care, and that's what we try to do each year. You've heard earlier from Jim that the outcome of the audit opinions was good. So for external audit, they gave us an unqualified opinion, and for the head of internal audit opinion, we received significant assurance. So both of those are the opinions that we are striving for each year, and I'm really pleased with the outcome of the audits. In fact, in terms of the annual accounts, there were only minor amendments required and nothing significant in terms of financial value. So we were really pleased with the outcome of those audits. During the year, we continued to spend money on COVID-related care, and our CCG spent £23.73 million, largely relating to two areas: the vaccination programme, but also the line underneath, which shows the hospital discharge programme. And that's where we were able to access resources to support discharge of patients from hospital in order to free up capacity. And we undertook that process jointly with the local authorities and supported financially the first 4 weeks of care where patients required support in a facility. Next slide, please. So this slide just highlights some of the key financial figures rather than delving into the technical financial statements. We've got here a table on the left-hand side and then a pie chart just representing the financial expenditure of the organisation. So we received £2.64 billion, and just over 50%, in fact 53% of that, was spent in the acute hospital care sector, predominantly within our local area, but we do buy care also from neighbouring systems. So £1.5 billion spent on acute hospital care. We spent £306 million, or 11%, on mental health and learning difficulties care. Community care, we spent £316 million, again just slightly higher, 1% of 11% on community. Prescribing, £245 million, and that represents 8%. Primary care at 10%, or just around £280 million. And other services of which we commission from local provider organisations, the voluntary sector, private healthcare, and those sort of areas, £183 million, which is about 6%. And the final one on there, the smallest bar you can see, is the running costs. That's at the bottom of the table, £24.1 million, and that's just under 1% of our expenditure. But in previous years, the CCGs have delivered surpluses, and those are accumulated each year. We're not able to spend them without permission, but we are able to carry them forward notionally against our organisation. And those have amounted to just over £51 million previously. So that is brought forward again against our organisation from the previous years. We add the £6,000 surplus and then carry that forward into the 22-23 financial year. Again, we're not able to automatically spend that resource, but we are able to call on it if we do fall into financial difficulty with the permission of NHS England. And finally, the note at the bottom just highlights how much we spend on patient care on average per patient. And during last year, that amounted to about £1,905 on healthcare for each patient registered within our CCG. And as you can see, we have just over 1.5 million patients registered within the Black Country and West Birmingham. Next slide, please. There's quite a key performance measure that we try to achieve each year, and it's called the Better Payment Practice Code. And the measure is how fast we are able to pay our invoices. We strive to pay 95% of our invoices within 30 days, and it's a code which is industry-wide. It causes organisations and companies significant cash flow difficulties if particularly large organisations like ours don't pay invoices promptly. So we strive to achieve that. The target is 95%, and you can see both in value terms and also in volume terms, we've achieved each one of those targets during the year, and in value terms, we're hitting about 99%, which is really good. I'm really pleased with that performance. We try to support particularly local companies and pay them promptly in order to avoid any cash flow difficulties, and that's been quite crucial over the last 2 years. Next slide, please. So within particularly the previous slides, 2 slides ago, you could see the area where we spend our resource, and these are the key providers within the main NHS providers within our system. And you can see here how much we spend with each of those providers. So Salmon and West Birmingham, £431 million during last year. Black Country Healthcare, delivering mental health and some community services, £202 million. Wolverhampton, £385 million, and so on. Just to note as well, with West Midlands Ambulance, where we spend £140 million of resource locally, we're also responsible for commissioning that care on behalf of the whole of the West Midlands. We are the lead commissioner for ambulance and most of 111 services, and in particular for all of the services of West Midlands Ambulance, and we lead on that commissioning care. And if we could move on to the next slide. Looking forward, the CCG, as you're aware, will be disestablished on Thursday this week, and the new integrated care body begins on the 1st of July. So some quite substantial organisational changes happening this week. And also on the 1st of July, the boundary national policy around boundary alignments with local authority boundaries will affect our CCG, and the West Birmingham practices and patients will be reassigned to Birmingham and Solihull CCG. That means we'll be transferring financial resource to support that, and we've been working with colleagues in Birmingham to ensure that the correct amount of money is transferred to support that. And the estimate at the moment, which we have agreed on, is about £304 million full year. Obviously, we're transferring a part year value this year, but that will transfer along with the patients and GP practices over to the Birmingham and Solihull CCG, which will also become an integrated care body on the 1st of July. Other challenges going through 22-23, we've already started the financial year, and previous years there have been different financial arrangements than we would normally expect because of the COVID arrangements, but we are now returning back to the usual NHS financial flows arrangements for our resources. And as COVID levels reduce, the amount of expenditure that we're incurring is reducing, but also the resources are reducing as well. And this is causing some challenge within the local system, and that will be a big focus going through into 22-23. Also, as we try to recover services following COVID, tackling waiting lists, etc., This also causes a significant challenge both in capacity terms but also in expenditure terms, and we are incurring more expenditure. We have been funded to a certain level, but it would be important to ensure that we're able to balance off the amount that we spend against those additional resources that we have received. And of course, that takes us into the territory of needing to ensure that the efficiency programs that we operate and any cost reduction schemes are successful, and of course we'll be focusing on those to ensure that they are going through next year. That's all I wanted to cover. I'll hand back to Mark. Thank you.
Thank you, James. As Jim said in his audit presentation, it was great last week at Audit Committee and at CCG governing body to hear such positive comments about the report and accounts for 2021-22. And James, I'd just like to say thank you to you. This is your last AGM with the CCG. I know you're moving on to new roles from the 1st of July. And it's never easy doing NHS finance in the best of times, but in what are uncertain times, even more challenging. And it's testimony to your leadership and to the finance team that we got such a good audit report. So I'd like to place on my record my thanks to you, James, for all your work for the Black Country and West Birmingham CCG, but also Sandwell CCG before that. So thank you. As James has mentioned, on the 1st of July, the CCG will be disestablished and the integrated care body created, and that will mean a boundary change. So I'd also like to say a huge thank you to West Birmingham colleagues as they transfer over to Birmingham, particularly to our GP colleagues and to staff. But as we move forward, what we're trying to do with this change that's come through the Health and Care Act on the 1st of July is really start to embed some of the things that have guided us and supported us as we've lived with COVID over the last 2 years. And on this slide, you'll see a kind of description of what integrated care systems are, and hopefully through the discussions and the presentations you've heard already, it's about partnerships, working across organisations to learn, to plan services and to join up health and care services to improve the lives of the people in our area. And that's based on the feedback that you've given us, based on the feedback and the learning from COVID, but also based on some of the data and the evidence that demonstrates that there is so much more to do. And you'll see on the left hand side of there that we have 4 purposes really. One is to improve outcomes in population health and healthcare. So that includes making sure that our services are delivering in the very best way they possibly can, that they're joined up, that access and the challenges that Matt has described around access continue to improve, that we use the money that we have in the most productive way and make sure that we are enhancing productivity and value for money with the money that we get given as an NHS in the way we deliver services. So as much of that Black Country pound as possible is spent on delivering frontline patient care, and we're maximising the opportunities to learn from digital, to learn from clinical innovation, both in the Black Country, but also from across the country and internationally, if need be, to maximise patient care, to tackle inequalities in outcomes, experience and access, and to support broader social and economic development. And that final one, I think, is very important, to recognise our role as a major employer, as somebody who pays a huge amount of businesses locally in the Black Country, and can we do more to support local businesses, but also to recognise our role in terms of economic and social development, working with our partners in local authorities, working with our partners in the voluntary sector, chambers of commerce. You'll have heard the government talk about the levelling up agenda and the opportunities to support levelling up communities, and that absolutely is part of improving healthier life expectancy. And the benefits on the right hand side, well, continue to support those with long-term conditions or mental health issues to live well, supporting people to stay well and independent, improving the health of children and young people, getting the best from our collective resources so people receive care as quickly as possible. We have launched and implemented the Share Care Record, which is an opportunity for records to be shared across all our health and care partners, particularly recognising that that information is really important. So, for example, if you're treating somebody with a mental health condition, you understand their physical health condition, or vice versa. Or if you've been referred from primary care into an acute trust, that your information travels with you. You don't have to tell your story twice. Caring for those with multiple needs and acting sooner to help those with preventable conditions, and making sure we're doing all we can, particularly around some of the health inequalities and the wider determinants of health around health prevention. Because what we absolutely recognise is that quite often when people prevent to health services, there are things that could have been done earlier to support them in their communities. And actually it's the wider determinants that sometimes contribute towards people's poor health. That can be loneliness, housing, education, and we want to work with partners to address those issues. Next slide, please. So on the 1st of July, there will be two parts to what we established. So the Health and Care Act 2022 has established 42 integrated care systems across England, and in each of those integrated care systems, and ours will be the Black Country Integrated Care System, there will be two parts to it. Firstly, an integrated care partnership, or ICP as we will call it, because we love our acronyms in the NHS. And this will be a statutory committee formed between the NHS Integrated Care Board, all upper tier local authorities, and the aim of this will be to bring together that broad alliance of partners to focus on improving the care, health and well-being of the population. In Matt's slides, you will have seen him feedback on the work we've done with health and well-being boards and some of the positive comments that we've received. And it's absolutely about, through that integrated care partnership, what are our priorities through each of our places, Dudley, Sandwell, Walsall, Wolverhampton, that we want to develop further, particularly around health and well-being with those partners in our places. But equally, what is it we want to develop and tackle once at a Black Country level? Because when we look across each of the health and well-being plans for the local authorities, there are things that are the same challenge. And could we scale up and do something for a population of 1.3 million rather than doing it individually in 4 places? But also one of its early priorities, and we'll definitely be talking about this time next year, is to produce an integrated care strategy for the Black Country that is steeped in place in those 3 boroughs and 1 city that we've described, but describes how working in that partnership with wider partners, local authorities, voluntary sector, education partners, housing, you name it, to address the health and well-being needs of the population that we serve. And then the other part is the statutory NHS organisation, the Integrated Care Board. That will be the body that on the 1st of July, the CCG will cease to exist and it will become the Black Country Integrated Care Board. And as a statutory NHS organisation, its responsibility is for developing a plan for meeting the health needs of the population, managing that NHS budget that James has just described, and making sure we have plans in place for provision of health service right across our ICS. And clearly, as it says there, when ICBs are legally established, clinical commissioning groups will be abolished. But just to be clear, because I get this question a lot, the question I get regularly is what's happening to the CCG staff? They will all transfer across on the 1st of July. And that's part of some of the workforce slide that we put together about that management of change. So the title we changed, we've gone through a process of recruiting to the board, who I'll introduce you to at the moment, in a moment. But for the vast majority of staff, with the exception of those from West Birmingham that will transfer to Birmingham, they will transfer across from the CCG to be part of the organisation that is the Integrated Care Board. Next slide, please. But we need to build this integrated care system on its strengths, really, and they are probably threefold. Firstly, place-based partnerships. So place-based partnerships in all 4 places of the Black Country, as I've described, Walsall, Wolverhampton, Sandwell and Dudley. will be responsible for designing and delivering of integrated care services across their localities and neighbourhoods. This is all about how do we bring services together and integrate them at the best population level to get the best outcomes for you. So if need be, that can be a neighbourhood very much centred around a GP practice, or it could be a service that's delivered at a borough level. And those partnerships are actually already in place, and in our first year as an integrated care board, we really want to see them flourish and develop. And the partnerships will involve NHS, local councils, community and voluntary organisations, local residents, service users, and it's really important that through those partnerships we are making inroads into tackling health inequalities and improving those outcomes that are described in our purpose on the previous slide. Provider collaboratives are also a strong part of what we want to develop as a system, and that will bring together NHS providers to achieve the benefits of working at scale across multiple places, and even possibly across more than one integrated care system. And that's as much about quality and safety as it is about efficiency and outcomes, and using that black country pound, as I described to you, to get the best outcomes in terms of unwarranted variation and inequalities. So two examples of where I think provider collaboratives are working. One is Matt described in his slides, the immense effort that's going on to manage and reduce the number of people waiting for elective surgery. The 4 acute trusts are managing that as a group, which enables us to make sure that where potentially one trust cannot offer an operation or a procedure to an individual, we're actually potentially able to offer and treat them in another trust and get them treated as quickly. Another example is, for example, CAMS inpatient beds, which we know there are not enough of. There is a provider collaborative operating at a West Midlands footprint, because we think that's the right scale for that kind of specialist service, to be able to create more capacity around CAMS inpatients. So we expect to see provider collaboratives across our acute colleagues who are developing this and leading the way. Primary care are developing a provider collaborative that will particularly focus on what we need to do to continue to develop primary care at scale across the Black Country. And our mental health learning disability provider have taken on lead provider responsibilities and are involved in some of the work of the West Midlands Mental Health Provider Collaborative. And then our local authorities, we've developed a really strong relationship with our 4 local authorities, and they recognise the benefits of working closely together with us and us working with them, particularly around social care and that public health agenda, in developing plans to tackle health inequalities and to support, and this is where I think we can learn more from local authorities, that broader social and economic development. Next slide, please. So this is a visual of what it will look like. So Healthy Futures Black Country Integrated Care System will have an integrated care partnership that will focus on integrated care strategy, how each of our places and health and wellbeing boards are working together to deliver. And then the NHS Integrated Care Board, which is about planning and buying NHS services. And underneath that will sit, I think, a structure that recognises the way people live their lives in the Black Country. So we absolutely, where appropriate, want services to be dialed into neighbourhoods, 30 to 50,000 people, the communities that you live in, particularly around multidisciplinary and integrated care working linked to primary care networks. At place level, through our place-based partnerships, circa 300,000 people, that we're doing all we can to integrate services and to tackle the wider determinants of health. And then at a Black Country level, through our provider collaboratives, how our voluntary sector is working together, we're challenging ourselves on how we can reduce variation, how we can improve clinical standards and population health outcomes, and where appropriate, implementing services for a population of 1.3 million, and in particular where they're very specialist, that are sustainable, and that make sure that wherever possible people access services within the Black Country. Next slide, please. The board of the ICB, you can see there, I think that describes very well. We have 2 partner members from trusts, 2 partner members from local authorities, 2 partner members from primary care, our non-executives and executives, as well as our chair, Jonathan. Next slide, please. And these are our non-executive directors who you will get to meet as we hold our integrated care board meetings in public. They come from a vast variety of backgrounds. We have GPs, we have colleagues that have worked in housing, colleagues that are currently working in and leading boards in other health systems or with the university. Some come with a private sector background and bring that industry experience. And the non-execs are the independent members of the board who will challenge everything we do and scrutinise everything we do to make sure we are delivering on those 4 priorities, that purpose and the benefits that we've described. Next slide, please. And then our executive officers who we've been appointed through a recruitment process. So I, as you may have seen over the last few weeks, now confirmed as the permanent Chief Executive Officer for the ICB. Matt, who you've met, who's our Chief Operating Officer. Sally, who many of you will know, but unfortunately she's on leave this week, our Chief Nursing Officer. Shajida Ahmed will join us in September from Staffordshire Integrated Care System as our Chief People Officer. Tom Jackson, who was formerly Chief Finance Officer at Dudley Group. And Ananta Davi, who was previously Chief Medical Officer at Lincolnshire Partnership as our Chief Medical Officer. Next slide, please. And to be able to explain this to you in a better way, we've actually produced a film, and the comms team hopefully are going to come in and play this to you now.
Hi, my name is Jonathan Fellows, and I'd like to take a few minutes to tell you about the integrated care system we're building in the Black Country. In particular, I want to talk about what an integrated care system is, what it will do, and why we need one. The Black Country has a population of nearly 1.3 million people, and it covers the 4 boroughs of Dudley, Sandwell, Walsall and Wolverhampton. It was one of the birthplaces of the Industrial Revolution, with coal mining, iron foundries, glass manufacturing, brickworks and steel mills, all creating high levels of pollution. The first time this area was called the Black Country appears to have been almost 200 years ago, in the 1840s. It might have got the name because of the soot and the smoke from all those industries, or perhaps it was because of all the coal seams close to the surface. What is clear, though, is that although the heavy industries have now largely gone, their legacy lives on in terms of the impact on the health and the well-being of the Black Country population. Sadly, many people in the Black Country don't live as long as those in other parts of England. A lot also don't enjoy good health and face other challenges. There is a great deal of poverty and deprivation in the Black Country. Just under half of all the people in the Black Country live in some of the most deprived areas of England. There are also more people in the Black Country who don't have jobs, don't have qualifications compared to the rest of England, and children don't do as well in school as in other parts of the country. Healthy behaviours and lifestyles are also important when looking at people's health, as these lead to more people living with long-term conditions and ill health. The reason we need to alter how we're providing health and care to our population is so that we can work alongside our communities to start to change some of those outcomes. It won't be easy, but that mustn't stop us from doing everything possible to make a difference. The population of the Black Country is very diverse. Overall, around 30% are from Black, Asian or minority ethnic communities, although in Sandwell that's a size 40%, and in Wolverhampton it's 39%. Communities include people from Bangladesh, China, Gambia, India, Italy, Jamaica, Nigeria, Pakistan, Philippines, Poland, Somalia, Zimbabwe and Yemen. We need to make sure our health and care services are easily accessible and available to all of them. The environment in which we're born, grow up, live, work and age in, as well as the decisions we make for ourselves and for our families, have a bigger impact on our health than healthcare alone. We know that differences in health outcomes and life expectancy, as well as opportunities for good education and job prospects, don't affect everyone equally. So a one-size-fits-all approach won't work. We need to work with each of our communities to help identify the specific problems to tackle, and we'll also need their help to come up with the best solutions. The COVID-19 pandemic has shown us how health and care services can work together better. All services played their part, with GPs, councils, voluntary and community groups working together in local neighbourhoods to reduce isolation, tackle loneliness and support those most vulnerable, while hospitals work together to share resources, look after a lot of people suffering from COVID-19 and also ensure that people who are ill could still get the treatment they needed. But even with all of the great examples of our health and care systems working together and breaking down barriers, we know that for some of our communities, COVID-19 has led to inequalities increasing, not reducing. If we were to carry on as we are, we'll need more hospitals, more care homes, and a lot more health and care workers. Not only is this unaffordable, it also wouldn't be the right thing to do, as it wouldn't help people to live longer, nor help them to live in better health. We need to change. One of the most important things to realise is that health cannot be improved and health inequalities will not be reduced by the NHS acting alone. Although improving the quality and accessibility of health and care will play a part, there are many other factors such as income, education, employment, training, housing, the environment and crime that all have an impact. Only by working together to deal with all of these factors will we start to be able to make a difference. So our integrated care system is a partnership across health and care providers, local authorities, voluntary and community organisations, the police, fire services, housing, education, colleges, universities and large employers aimed at coordinating services better, improving the health and the lives of Black Country citizens and starting to tackle and reduce the inequalities that exist between the different communities across the Black Country. By working together with partners from our integrated care system, we want to improve outcomes when people need hospital care and treatment, improve the health of our Black Country population, remove the inequalities that we currently have in access to health and care, provide care that focuses on the person receiving it and makes the best use of their time, connect health and care services in a more joined up way so that we can make better use of the money we have, and play our part in improving education, training, employment and housing to give our communities better prospects. I said earlier, none of this will be easy, but I also said that mustn't stop us. By 2030, with more people living into old age, some of the things that will help us to know that we've succeeded will be if people are living longer and healthier lives, people are staying healthy in their own homes and communities, people are taking greater responsibility for their own health. When people need hospital care, they get the best care at the right time, and prospects for education, employment and housing are much better. However, there are also two other groups that it will be vital to have deeply involved if we're going to succeed. The first group are the communities we serve, who need to tell us the things that need to change and help us to find the right answers. And the second is all of the people that work in health and care. They have a vital role to play, as they will know what changes will make the most difference. They will know how to do things better, and we need to involve them. Most of the time, our people and our communities know what the solutions are. So we want to listen to them, work with them and support them so that together we can make the right things happen. This will be a new way of working, putting people and communities at the centre of the whole system. I hope you will all want to play a part to help make a difference and to deliver a healthier future for everybody in the Black Country. Thank you.
Thank you, and I hope that video, which I think encapsulates really well what we're aiming to achieve as an integrated care system, has been helpful. Next slide, please. So we are coming to the questions in a moment, so I shall be going over to the chat to have a look at the questions and to pick those up. Clearly, we haven't been able to cover everything that's been achieved in the last year, and we've really tried to pick out the highlights. But if you want more information, there is information available on our website now. So the annual report and accounts are there, and a summary version of our year is there, and the slides that we've used today in our AGM are there, and you can see the link to the website that contains that information. As we go into the questions, as I said at the start, if it's about an individual case or is around sensitive issues, we cannot discuss those in the AGM, but our time to talk team are always there. If you've got a particular concern around care or experience that you want to raise, and you can see their details on there, both their email address, phone number, and also some social media accounts that you can contact us on. Next slide, please. And then on the 1st of July, as with the change, this is how you can keep in touch with what we are doing. So across Facebook, Twitter and Instagram, NHS in Black Country, you can see it there. Underneath each of them is the best way to keep track as we become an integrated care board and start to deliver on some of the things we've set out in this presentation, and to develop ourselves as a system. And equally, our time to talk team will be there as well, and our website will be blackcountry.icb.nhs.uk. Next slide, please. So let's have a look into the questions that people have submitted in advance. I do have one question that was submitted in advance. Let me just find it, which I will read out and then respond to. So a question from David Hellier. Hello, David. When and how will the networks and patient participation groups be reactivated in Wolverhampton, with particular reference to there being face-to-face and not via Teams, Zoom or other remote methods? So David, a huge thank you for your question. And we absolutely, CCG absolutely sees, and as we move forward, we're absolutely committed to involvement and engagement with these groups. And if you go to the annual report on the website that I've just said, you will see lots of examples of that involvement work. But naturally, because of COVID-19, there have been some limitations to this. So at a practice level, we do expect that each practice has a patient participation group, and whilst we don't manage these, we are able to offer support to practices who need it to get these panels working effectively. And we have held recently, and I had the pleasure to go to one, some face-to-face involvement events, and we're thinking now that the time is right to continue to build that up, always being mindful of community infection rates. As we transition from CCG to Integrated Care Board on the 1st of July, we have a new approach to working with people and communities that kind of takes away the formality of patient panels, with less emphasis on them, and more in our focus on our teams working with partners, community and voluntary groups, and getting out into communities to really listen to the views of local people. I said at the start of this session that, you know, the COVID vaccine and some of the vaccine hesitancy really showed us the value of building trust and reaching deep into communities and listening and acting on their feedback. So existing mechanisms for patients to have their say, such as citizens forums, haven't operated with the frequency or regularity we would like. We've also had some capacities in the engagement team, but it's great that we are now back up to full capacity, and the ICB will have regular public meetings and community involvement events in each of our 4 places. They're scheduled to kick off in August, September time, and the opportunity is the hope that these events will bring together colleagues and stakeholders from right across the patch. So details of these opportunities will be on our ICB website very, very soon and advertised locally. But David, we will pass on your details to Stephen Terry, our new head of involvement, so he can pick up a follow-up conversation with you if that's okay. Let me just go through the other questions. A comment from Tom, and actually I would echo this, and I think it's felt by every member of the staff in the CCG and actually by NHS and care staff right across the country. And Tom says, I would like to thank the whole of the Black Country public community for the support and messages of thanks that has been given to us as NHS colleagues. During the pandemic, hearing people's gratitude, the special offers and incentives that were provided, and hearing good news stories when patients were able to return home was massively inspirational and much appreciated during such an unprecedented time for us all. Absolutely, Tom. I think everybody would echo that. It seems a long time since we all stood on our doorsteps on a Thursday night and clapped the NHS, but I know that goodwill and support for the NHS hasn't disappeared. And as we go through the next challenge, it's really important that we have that support of our public as we deal with those challenges. A question from Teresa Culverwell. Could Sandwell and other authorities please prioritise helping those who hoard? There is a huge need for training of both professionals and patients with hoarding issues. Hoarding is a recognised mental health illness. It has a huge impact on everyone and has no doubt increased due to COVID, with less support being made available. Sandwell's priority is to work closely with local people, partners and providers of service. Please could Sandwell and other authorities make dealing with hoarding issues as a priority urgently. Matt, obviously the Managing Director for Sandwell reports to you. Would you like to just make a few comments and maybe link people up?
Yeah, sure. Thank you, Mark. Teresa actually wrote to us beforehand. So when you did that, Teresa, we've been in touch actually with those individuals who work within Sandwell and predominantly the place-based partnership. So I described earlier what they will do. So Sandwell's is called Sandwell Integrated Care Partnership. I've passed on your contact details. They're having a conversation on the issues that you've described there on hoarding, which, as we know, is an important issue. So I've asked for them to contact you directly. If you don't hear anything from them in the next few days, please do get back in touch with me or get in touch with me directly as well, and we'll pass those details on. So work has already started on that, and you should hear from us very soon, Teresa.
Thank you, Matt. Just looking through another comment from Teresa. I appreciate PPG's patient participation groups and training. However, please be aware that I attended my local meeting regularly at Black Country Family Practice, but have been missed off any virtual meeting invites for the last 2 years. Please be aware of not just using your attendance list from your last set of minutes. You need more people to attend and raise awareness of needs, and we appreciate being listened to and seeing actions being taken around issues we raise as patients. Absolutely, Teresa. If you want to drop your contact details through to the Time to Talk team, as we start to develop the new way of working and develop our engagement and involvement processes as an ICB, and we talked about some of the events that we'll be holding in the autumn. If you'd like to be involved with those, then we can send you those. If you send you the details for those, if you drop us a line. Thank you for that. An anonymous question: how much money is the CCG spending to create the new NHS organisation in Dudley? Is this a good use of money? So for those that you're not aware, on the 1st of April 2020, as a result of the merger between Black Country Partnership and Dudley and Walsall Mental Health Trust, one of the organisations was used to create an organisation in Dudley called Dudley Integrated Health and Care. The aim of that organisation was to focus on some of the things we've described in this presentation around integration between services from mental health, social care, children's services, primary care, acute services. I don't have the exact details of how much the CCG has spent on that creation of that organisation. Is it a good use of money? Well, certainly over the last, since I came into role in November, when you look at some of the performance across our places, I think particularly about vaccine uptake, I think particularly about the rollout of extended hours access for primary care, Dudley has led the way, and Dudley Integrated Health and Care have been an absolutely integral part of that. So I have seen benefits in terms of how we deliver services at place in Dudley from the creation of Dudley Integrated Health and Care. There is more work going on at the moment to conclude the clinical model for Dudley as a place that will go through that Dudley place-based partnership that involves clinicians from all organisations. And then once that's concluded, decisions will be made on kind of development of Dudley as a place. So I'm sorry, I don't have the exact amount of money. James had in his slides the amount of money that we contract with Dudley Integrated Health and Care, which I think was 14 million, was it, James? But beyond that, I don't have that information, unfortunately, to hand.
Yeah, well, it's 14 million pounds that we spend with Dudley Integrated Health and Care.
Thank you. Another comment from Teresa. I'm glad that you LD on your radar. However many services are concerned about insufficient knowledge of LD learning disabilities, especially those with more complex needs, e.g. need 24/7 support when in hospital, need high-sided beds so they don't fall out, need to be considered if they are 18 plus, but with needs of a 12-month-old, and where to place them in hospital, etc. Staff and parents have had their concerns for many years. Could you please provide more training to NHS professionals and carers with lived experience to provide that training? Thank you for that, Teresa. I actually chair the Learning Disability and Autism Board for the Black Country, and I will take that feedback into that discussion next week to make sure that where we are delivering training for staff across the organisations that are involved, that it does pick up that lived experience, as you've described. Very, very important. A comment from Lindsay with the link to the annual report. A comment from Masood. It's been an honour to serve the population of the Black Country in West Birmingham as CEO, and I wish the future team all the best. Absolutely, Masood, and we wish you all the best as well. A comment, thank you for the responses to the questions from Teresa, and absolutely not a problem, Teresa. That is what we're here for, to receive your questions, to be accountable and to answer them when you raise them. So actually, we should be thanking you for submitting them into the chat. So those are all the questions that we have submitted. As always, if you've got any further questions, please do get in touch. This time next year, we'll have had 1 year of being an integrated care board, a lot to deliver, working very closely with our partners across the Black Country. Lots of opportunity to improve how we deliver services, to tackle some of the post-COVID challenges that we've had, and to work really, really closely with our communities, particularly around health inequalities. And I look forward to presenting you in 12 months' time with progress that we've made. But on behalf of the CCG governing body, a huge thank you to everybody that's worked with us during our life as a CCG. A huge thank you to our staff and to the governing body who worked with us, delivered and led the organisation. And thank you for attending this annual general meeting. Take care.